This is Cate Swannell for the MJA, and our special guest this morning is Professor Lyn Gilbert, who is Westmead Hospital's Director of Infectious Prevention and Control, and is also the federally appointed Tsar for Ebola. That's an odd phrase, Professor Gilbert, but thank you for joining us this morning. How does it feel to be a Tsar?
Well, the Tsar title was entirely the invention of the ABC. It actually bears no relationship to my actual appointment, which is as chair of an advisory committee for the Australian Health Protection Primary Committee. And what this group, which is called the Infection Prevention and Control Expert Advisory Group, fairly mundane title, has been asked to do is to try to draw up national recommendations and guidelines for prevention of the spread of Ebola should it come to Australia. And that's exactly what we're trying to do.
It's been just over a month, I think, since you were appointed. How's that process going?
Well, as you might imagine, quite slowly. We have an excellent advisory group that we've pulled together with a lot of expertise amongst doctors and nurses with expertise in infection prevention and control, and in general a reasonably good consensus about the details, but the details is exactly what we're about, and so many of the points have been discussed at length, as you can imagine.
Yep.
Argued about. We've eventually come up with a summary of the recommendations for the use of personal protective equipment, and that's been back to the parent committee several times. And of course the AHPPC has representatives from each of the states and territories, all of whom have had input, and there are some differences between the states and territories, and we have spent quite a bit of time trying to come to a consensus which will allow for some not surprising differences between different states and territories in how they manage this. What we want to do is to try and have guidelines that are evidence-based and that acknowledge the fact that there are often more than one appropriate ways of doing these things.
Is there any one particular sticking point in terms of consensus?
I think that we have come to the point where our initial document, which is 4 or 5 pages, will be accepted by the AHPPC in the next few days. It's really just minor wording issues at the moment, but I think we have pretty general consensus now from everybody.
Can you give us a bit of an update on the situation in West Africa and also here?
Yes, well, the situation in West Africa is always a bit hard to keep track of. I heard on the news this morning that the number of deaths has been increased, according to WHO figures, from close to 6,000 to nearly 7,000, right? And from what I can gather, I don't think that really means that there's been an extra 1,000 deaths in the last week since the previous data were released. I think part of the recent organised program that is being coordinated by the United Nations. The United Nations mission for Ebola emergency response, or UNMIR, has been to improve surveillance of cases and deaths. And I think that in the past, the numbers of cases and reported deaths have been very much an estimate. And my understanding is that now the data are becoming more accurate. And so I think this is probably more cases and deaths being recognised rather than a significant increase, because there does seem to be a slowing in the numbers of cases, at least in Liberia.
Yeah.
This doesn't mean that we can breathe a sigh of relief by any means. There are still a lot of cases occurring. This disease is widespread in the 3 most affected countries, Liberia, Sierra Leone and Guinea. The situation has improved to the extent, I think, that there are now more hospital beds. There's an increasing number of foreign healthcare workers coming in to assist, although, of course, they are relatively small numbers, and there's some difficulty in recruiting local healthcare staff because so many of them have been working really under enormous pressure for the best part of nearly 12 months now, and so local resources are stretched, and it's going to be a long time, I think, before this is all brought under control.
Yeah. And the situation here, are there any healthcare workers under surveillance since their return, or?
Look, I don't know specifically who's under surveillance at the moment. All of the states and territories probably have a few people who've come back from these regions, but I don't have the details of those. But certainly I know that there are no positive cases. The main NGOs have people coming back at regular intervals, and they are supervising them when they come back, and obviously the local state and territory health departments will be notified if any of them have become ill. But I'm not sure. I'm sure there are some, but I don't know exactly how many or who they are.
Right. Is it your impression that the media's interest has died down a bit, and that, is that a good thing?
Well, there certainly hasn't been as much interest. I haven't had as many calls from the media asking for interviews in the last 3 or 4 weeks, and I think that is a good thing. Not because, I mean, we need to understand what's happening, and I think the international community in general needs to be aware and not to stop caring about what's happening in West Africa. What's happening here as far as in actual infections is concerned is nothing at all, and that's great. And hopefully it will remain that way, although there's a lot of activity going on in terms of training of healthcare workers and preparation in the designated hospitals, preparation by state and territory health departments for managing cases and so on. So there's a lot of activity locally, but none of that needs to be in the media or being scrutinised. I think the most important thing, though, is that when necessary, the public is appropriately informed, because there have been some quite excessive overreactions, I think, about people who've come back from West Africa being unnecessarily ostracised, stigmatised as a result, and when they pose absolutely no risk to anybody else. And I think that's going to be a challenge if and when we eventually see a case of Ebola.
Is that inevitable, do you think? That we'll see a case?
Inevitable?
Yeah.
Well, I don't think anything's inevitable. There's an enormous amount of effort being taken to ensure that people, Australians who go to West Africa, who are working for either the NGOs who have been active there for a long time, or for Aspen, the private company that's been contracted by the government, to make sure that they're appropriately trained and that they have adequate supplies of personal protective equipment. And if that happens without mishap, then really they should be at very low risk of becoming infected. And so I think that there's every chance that we won't see cases. We obviously can't predict whether there might be other people, travellers and others coming from West Africa, although clearly the Australian government is going to a great deal of effort to try to ensure that people with infection don't come to Australia. And of course, increased border security measures that have been introduced in the last couple of weeks are designed to identify people coming from that area and make sure that they are, if there's been any history of exposure to Ebola virus disease, that they are in contact with their local public health units and that their health is monitored during the incubation period.
Why are we so afraid of this disease? I mean, there are huge differences between life in West Africa and life here. Why does it, when it's killing so few in comparison to, say, malaria or tuberculosis, why are we so terrified of it?
Well, that's a good question, Kate, and I think it's to do with human nature in many ways, that it's something exotic, it's something foreign and horrifying. I mean, it clearly, there's a very high mortality, there's no denying that, although I have no doubt that in Western countries, overall, there haven't been very many cases yet in Western countries, so we can't tell what the mortality will be, but I'm sure it will be a great deal less than it is in West Africa because we simply have better facilities for caring for people. But there's a very high mortality, there's no specific treatment, and unfortunately, after months of taking not much notice at all of this outbreak in West Africa, as it was spreading very widely, as soon as a couple of cases occurred in the United States, suddenly everybody became aware of it. And the sort of horror of the unknown, I think, is really what's driving this fear in Western countries.
You wrote, back in August, you co-wrote a piece for The Conversation on the morals and ethics of Ebola, and you said there were, I think, 4 steps towards making things better. Do you have to separate that part of your brain from the job you're doing now? Are you always thinking about those things, or is it something you just have to concentrate on the nuts and bolts of getting it right at this end?
Well, look, I don't think I have to suspend my opinions about these things when they're evidence-based and related to what I know as an infectious diseases physician about how you control disease. I mean, it seems to me that the major problem in West Africa has been that this disease is occurring and has been occurring now for nearly 12 months in countries whose health systems had been severely depleted by years of civil war and civil unrest, with really until just the very last few months before this started, very little help from Western countries in recovery. And you know, obviously this is complicated, and I'm not passing any particular views about the rights and wrongs of either international assistance or the local governments there. But the fact is that in the absence of hospital beds, isolation facilities, adequate healthcare workers, adequate supplies of personal protective equipment, this disease will spread. And as we've seen, that's what happened. Whereas in the however many years it is since 1976, when Ebola was first identified, 19 odd outbreaks have all been contained in similar countries relatively quickly. The biggest outbreak so far has been 420, up until this current one has been 425 cases. The situation in Nigeria is really quite interesting in the context of the current outbreak, because a person with Ebola went to Nigeria. He was not initially suspected of having Ebola virus disease. He was thought to have malaria, was treated in hospital without appropriate precautions until the diagnosis was made after some healthcare workers became infected. But with a very rapid and purposive response by the Nigerian government, with an adequately funded campaign to trace all the contacts, social media was used and so on to try and contain this. And in fact, it was limited to 20 cases and 8 deaths. And brought under control in a very short period of time, which shows what can be done in a country where the health systems are relatively stable and quite good. Because, to be honest, the thought of introducing Ebola virus disease into Lagos, Africa's largest country with a population of 21 million, was an absolute nightmare. But it happened, fortunately.
I mean, you're an infectious diseases specialist. Do you get tempted to go?
I'm extremely tempted to go, but I think it would be extremely inappropriate for me to go, and I don't actually think any of the agencies would accept me for a number of reasons, not the least of which is that I have not personally had experience of working in this sort of area. And I know that agencies like MSF and Red Cross and presumably Aspen are very keen to not have absolute novices who've not worked in this area going into this sort of situation. So much and all as I think I and many of my colleagues are extremely tempted to go and help and not desperately afraid of the potential consequences. But I think we would be people like me, not only relatively senior people, older people, if you like, but also people who have not had experience in working in developing countries could potentially be a liability. So they want experienced people at the moment as much as possible, or younger people who are likely to be able to go back repeatedly over perhaps many years.
Yeah. What's next for the committee?
We have as I say, we have a summary document at the moment. We've started to work on a much more detailed document in which we will discuss the background to our specific recommendations, the pros and cons and so on. We'll be working, so far the document we've written is largely related to healthcare workers in hospital settings mainly. We're working on some recommendations for first responders in the community, ambulance officers, fire and rescue people, and also to situations like decontamination of sites where patients with Ebola virus disease might have been, and a number of issues like that. Many more will come up. We've got quite a lot of work to do, which I think will take us, well, until this outbreak is finished. And to be honest, what I'm hoping, very much hoping, is that the recommendations that we make and the experience that the whole medical community has had from this will make everybody much more aware of infection control in general.
Yeah.
Because I think one of the reasons that cases of Ebola virus disease have occurred in Western countries, specifically in the United States, is that contrary to the hopes of the Centres for Disease Control initially, ordinary personal protective equipment and transmission-based precautions for infectious diseases, which ought to have been adequate to protect healthcare workers, wasn't, simply because, in general, most of our healthcare workers don't actually comply as we would like them to with infection control measures, partly because for most infectious diseases they're not particularly at risk themselves. In general, the motivation for infection control is to prevent spread of infection from patients to patients, so we don't do as well in protecting our patients as we do in protecting ourselves when we're really at risk.
What's the prognosis on the epidemic, as it were?
Well, I mean, I'm certainly not really in a position to make any judgments about that. I think the WHO are estimating that it will take at least until the middle of the year, but they are even being very cautious about making predictions. I think quite rightly, because it really is not possible to predict. There's still not anything like an adequate response from the international community, and they're still hoping, I think, that more and more healthcare workers will go there to help, and that more resources will become available. So I think it's anybody's guess. It could go on for a lot longer. But at least the initial prediction that the modelling suggested, where there might be a couple of million cases by early next year, I think have been modified to the point where it's assumed that at least the rate of increase will slow down and it might plateau off early on. But absolute control, I think, is going to take a lot longer than that.
All right.
Well, thanks, Cate.
Thank you very much. Have a good Christmas.
Yes, you too.
Thank you.
Thanks.
Bye.